Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to be and live on this land. As well, we recognize that webinar participants are attending this session from traditional Indigenous lands across what we now call Canada. Please take a moment to make your own land acknowledgements to the people of those lands, thereby actively participating in reconciliation as we navigate our time in this session, learning and supporting each other. Today, we're delighted to partner with the Canadian Institutes of Health Research to bring you Caregiver and Family Mental Health and COVID-19, a focus on autism spectrum disorder and eating disorder patient populations. Just a reminder that we record all our webinars. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well. And I'll pose questions to our speakers at the end of each of their presentations. And now I'd like to introduce our speakers for today. Dr. Vivian Lee is a postdoctoral fellow working with Dr. Jonathan Weiss in the Department of Psychology at York University. Her research focuses on the emotional and mental health of children and youth with autism and other neurodevelopmental disabilities. Dr. Jennifer Couturier is a child and adolescent psychiatrist and is the medical director of the Pediatric Eating Disorders program at McMaster Children's Hospital. She's an associate professor with the Departments of Psychiatry and Behavioral Neuroscience, Pediatrics, and Health Research Methods, Evidence and Impact at McMaster University. It's my pleasure now to pass the mic to Vivian.
Thank you so much for inviting our team to present findings from our Rapid Knowledge Synthesis report. And in general, this talk will highlight the findings from that report. And we're really interested in capturing the literature on the impact of the pandemic on the mental health and well-being for caregivers and families of autistic people. So autism is a neurodevelopmental disability, and individuals often present with social communication and interaction difficulties. They may also present with repetitive and restrictive behaviors. And you may find that in this talk, I'm going to alternate between the use of person-first and identity-first language, because I recognize that there are significant changes in the recent years in how we discuss, define, and describe autism. And even though I use these terms interchangeably, I do approach both with respect. In terms of the care of autistic children and youth, it can be quite challenging because they often present with complex clinical and behavioral needs. For example, they carry a particularly high burden of emotional and behavioral problems and mental health challenges. And this often means that the care of autistic individuals may include a number of supports and services, including teams of healthcare professionals, therapists, and educators. Well, what about caregivers and families who care for these individuals? Caregivers of autistic people in general experience higher prevalence rates of mental health problems. For example, parents of autistic children, mainly mothers, often report higher rates of anxiety and depression compared to mothers of non-autistic children. And caregivers experience considerable demands and spend a substantial amount of their time addressing them, including acting as a therapist, now as an online teacher and homeschool teacher, an advocate, and navigator for the autism system. And not only are they managing the needs of their autistic child or youth, but at the same time, they're balancing their own needs for their mental health and well-being, as well as the needs of their family, for example, siblings and other dependents. So what do I mean by mental health? And I really want to highlight that when I talk about mental health, I'm talking both about negative states as well as positive states. And we hear so often about mental health and associated words such as anxiety, grief, depression. But I want to highlight that mental health can also mean positive states, as well as including self-care, intentional actions towards own well-being. And parents of autistic people often neglect to engage in positive states due to the many demands that they have to manage, which makes them more vulnerable to negative states, leading to serious mental health issues. So how are things before the pandemic? Well, in a study by Weiss and Lunsky in 2011, a survey was conducted with over 200 families across Canada. And families, mainly caregivers or mothers, were asked to rate themselves on a single item 10-point scale, ranging from 0, meaning everything is fine, my family is content, to 10, we are in crisis, we need help right now. And in general, from that survey, families indicated that things were often stressful. So they're in the middle here, where things were often stressful, but we were managing to deal with problems when they arise, or things are very stressful, but we're getting by with a lot of effort. It's important to note as well that some were in crisis too. About 11% indicated that they were in crisis. So given the demands of COVID, it seemed inevitable that the policies put in place to limit the spread of COVID, stay at home, these rolling lockdowns that we're all experiencing, would exacerbate the levels of distress for caregivers and families and make them even more vulnerable for mental health challenges moving forward. And it was crucial for us to quickly capture information that helped us better understand the specific experience of parents during the pandemic, including the unique stressors and demands that they might be experiencing. This was the objective 1 of our report. And at the same time, we're also interested in capturing evidence-based supports and interventions or information about these types of services that might have emerged in response to the pandemic that aim to support the mental health and well-being of parents during this time. It was important for us to take an integrated knowledge mobilization approach in where we collaborated with a number of researchers, clinicians, community stakeholders that advocated for families of autistic children and youth, as well as families. And so we had 4 caregivers who were part of our team as well. And we were thinking collectively about what was going on with these families and how can we better support them. So that was objective 2. I wanted to highlight that as part of this report, we took the Family Adjustment and Accommodation Resource Model, or the FAAR model, as a framework in which we used to search for this information. The framework is often used to understand the processes that lead to family outcomes in the face of stressors. And it suggests that response to stressful life events involves the interaction between 3 domains, which include demands, and demands are sources of stress, negative circumstances that persist over time. So of course, that is within the context of the pandemic, as well as capabilities on the other side of the scale. And capabilities are things like external resources, like programs and services available to families, as well as internal resources, things like coping mechanisms or coping behaviors. And these capabilities are what families employ to meet the demands as they increase. And the last domain that it highlights is meaning. So the meaning that families make of the experience through the pandemic, lessons learned, ways that situations are interpreted, and that family outcome is therefore determined by their subjective experience or meaning of how well they balance or how well they feel they're balancing their demands and capabilities. In terms of creating the report, we worked with a York University librarian with experience in advanced searches to help us make sure that we covered all databases. So we searched databases around the world. We conducted the rapid review based on the proposed methodologies guide of the Cochrane Rapid Reviews Method group. And the group of researchers, as well as our community-based partners and caregivers, came up with a list of search terms, and everyone verified their utility. So taking that integrated knowledge mobilization approach where everyone had a say. And you can see here that there are two columns. We had the same search terms for databases that dealt with evidence-based research as well as gray literature terms. And I'll go through what that means. So in terms of how we conducted the review, a PhD student in our lab, Carly Album, and I conducted 2 rapid literature searches between May 25th and June 12th, 2020, so quite early on in the pandemic. And we did a second search in August to update any new research that had emerged and any new reviews that was published. We used 3 strategies: traditional databases with evidence-based publications, as well as Google Scholar. And we also looked at gray literature, which included newspaper articles, published reports from not-for-profit organizations or government agencies. We also solicited from our research team and other experts any material or information that they have come across that would be relevant to our search and to our objectives. And I won't go through, in the sake of time, I won't go through in detail how we synthesized and selected the specific articles that we ended up reviewing. But I do want to highlight that through both searches, we found 298 unique articles, and we distill it down by excluding certain ones that were not relevant to 27 articles and reports that we included in our final analysis. In terms of the article characteristics, we included 17 empirical articles. So these are peer-reviewed, published in journal articles, and 8 countries were represented. We also used the Critical Appraisal Skills Program checklist, or CASP, to determine the quality of empirical data included in the study, and it was variable in quality. Not surprising considering how early on in the pandemic these articles were published. We also reviewed gray literature, so 10 gray literature articles, reports, and countries represented, including Canada, US, and Israel. So what do we find? Not surprising, parents reported a number of social disruptions and increase in demands due to the pandemic. There were incidences of loss of job or financial instability. Marital conflict was high on the list of reports from parents. Parents were reporting a number of demands, homeschooling being a huge number of demands and things that parents had to now deal with. There were increases in child behavioral challenges, abrupt changes in routine, loss of interventions and services, safety concerns because there was an increase in aggressive behaviors, including self-injurious behaviors. There was reports of strains in parent-child family relations due to the increase of demands for the parents, as well as some of the behaviors that manifested due to the pressures of the pandemic on the child. Across the different published reports, we found higher incidence of distress and mental health challenges in caregivers. So for example, 59% of parents reported feelings of helplessness in a Turkish report. Families that participated in the Pandemic Canadian Autism Needs Assessment Report or survey indicated that 43% were very stressed, and about 77% to 86% reported feelings of worry, anxiousness, stress, and depression and isolation. But what about the capabilities? So we were also interested in how families were engaging capabilities, what they were, and how they were helping them. So for example, caregivers noted that they were able to change the routines, even though there were abrupt disruptions or very quick disruptions to their daily routine. They were able to remake them for what worked for their family. They were able to change schedules and provide structure within their family so that they can adjust to their new normal. Some families indicated that they could depend on their community, neighbors, friends, and other autistic families and family support, even if it was socially distanced. Some families noted some positive, spending more time with their family, decreases in autism-related stressors, for example, struggles with transitioning into school on a daily basis. If kids were staying at home, they didn't have that stressor. Importantly, families noted that they were able to utilize phone or web-based technologies to access child services. So they were still able to access services even if it was adapted in some way. And importantly, these services were able to very quickly adapt the way that they were working with families, accessing families through web-based and phone modalities. So it seems like even though there was abrupt disruptions to some of these service deliveries, they were able to modify them to meet the needs of families. Importantly, though, no studies considered the effectiveness of mental health and well-being, the effectiveness of these programs in how they were working for these families. Was it feasible? Was it accessible? What kind of barriers were families facing in order to access these web-based or phone programs? In terms of meaning, when we were synthesizing all the literature that we had read, we found themes that suggested that families were staying connected with the autism community via social media, Facebook groups, or chats. And this was something that helped them feel less alone and reminded them that they had to take care of themselves. They had to take time for self-care in order to then continue taking care of their families. There were themes where families talked about family culture and the importance of family culture and how that served as a source of resilience. For example, families saying that they worked as a team, that every member had their responsibilities. They were going through this together. And family culture itself was something that helped families foster that cohesion and hope they needed to meet the demands that they were facing. So overall findings suggest that absolutely families of autistic people are stressed and are experiencing a lot of demands, and even more so given the current pandemic situation that we're in. And some families may also be in crisis because their demands far outweigh their capabilities, and they might not have the capacity to make meaning or shift their worldview to balance the scale. But we do find evidence that some families are coping, and they are engaging in these new strategies of coping to make things work. And some families, not all, have had some positive experiences through the pandemic. Service providers and educators are adapting their services to online delivery, and in some cases, making socially distanced visits or personalized home toolkits to help families cope during this time. But I think the key takeaway here is that we certainly have a responsibility and the opportunity to offer supports and resources to families, keeping in mind all the demands that they are experiencing. And we have to recognize that, or help them recognize their own capabilities, continue to support them, and hopefully help them feel like the scales are more even as we go through COVID together. Implications here are that we need to recognize the long-term impact of the prolonged distress that these families are in. And we also need some rapid research into the remote delivery services interventions. Are we missing any groups? Who's accessing these services? Are they accessible and feasible for all families? Importantly, I want to highlight that as part of our knowledge mobilization initiatives, have included sharing our findings with community-based organizations that service caregivers of autistic individuals. This includes through the partnership with a Kids Brain Health Network and MyTax grant. I've been able to present findings from this work with Autism Ontario Board of Directors and their Service Navigator team. I was also able to share this information with PART, which is a network of frontline workers in the child welfare system. And I was able to share findings to help keep in mind the mental health and well-being of caregivers of autistic children and youth within the system. So these findings and our report have been shared and hopefully are helping with the guidance of certain organizations and informing their considerations for parent and caregiver mental health and other needs. So that's the end of my presentation. I want to thank the Canadian Institutes of Health Research for funding our report. I'd like to thank our collaborators and the parents who worked together to develop and create this report. And I want to thank you all for listening.
Thank you, Dr. Lee. It's now time for a couple of questions. There's one in the question and answer box now. When you, and I encourage others to type your questions in while we take this first one. Otherwise, we'll move on to the second speaker. And if you have any other questions at the end, we can address them then. When you presented back to through those knowledge mobilization channels on a couple of slides ago, what kind of advice or feedback did those groups have for you, and did it change anything in terms of your recommendations for practice or policy?
That's a really good question. So with Autism Ontario, I was able to work with the service navigator team and give them information from the reports. And they were able to highlight some of the things that they were doing that help support the mental health and well-being of caregivers. So they're engaging in a program called CARES, that is a parent-mediated program all online that helps parents with some of the demands and struggles that they're experiencing. We're able to talk about how to support, again, remotely some of the families who have kids with higher needs or more complex needs, and how to set up focus groups with them to support their needs. And so with working with some of these groups, I was able to then feed that information back into the report to really highlight some of the supports that families were getting from community-based programs and how they were adapting them and the ways that they were thinking about families and their needs.
Thank you. There's no other questions in the question box at this time, so we'll move on to Dr. Jennifer Couturier.
Hello, everybody. I'm just going to share my screen here. Get the presentation going. Okay. Can everybody see that well? Hopefully.
Yes, we can.
Okay,
Thanks.
Super. So it's really my pleasure to be here today. I'm so excited to tell you about our findings from our knowledge synthesis. You may have heard reports in the media lately about the surge and the epidemic of eating disorders that are going on right now, likely due to the impact of the pandemic. So we've experienced a tripling in our referral numbers, and our admission rates are also skyrocketing with new patients. So this is a timely opportunity for me to tell you about our new guidelines that we developed through this project. And as mentioned earlier, I'm a child psychiatrist working at McMaster and the medical co-director of the eating disorder program at McMaster Children's Hospital. Just want to declare that I have no financial conflicts of interest, but I am interested in family-based treatment implementation, as well as dialectical behavior therapy implementation. And thank you to the funder of this project, CIHR. Just also want to acknowledge the generous donation of time and energy of our panel. These individuals are clinicians and researchers, as well as policymakers, as well as youth and parent advocates from across the country And they all devoted their time to talking about these recommendations that I'm going to present, as well as voting on them. And thanks as well to Danielle Pellegrini, who's my amazing research assistant. So here's a brief overview of my talk today, and hopefully we'll have ample time at the end for questions. So as I mentioned briefly, we knew that COVID was having a huge impact on individuals with eating disorders very early on. In March, our clinical program was forced, I will say, to transition very quickly to virtual care. We weren't allowed to have ambulatory services any longer, and we were allowed to have inpatient care. So we had to pivot very quickly to virtual means of treating our patients. And we thought, wow, I bet other people across the country are struggling with this issue as well. And there really are no guidelines in terms of how do you treat children and adolescents with eating disorders in a virtual world. Our group, our panel, had worked together just very recently to develop Canadian practice guidelines for children and adolescents with eating disorders in the real world. So we had recently published these guidelines in February 2020, and we thought, wow, this is a good opportunity to develop an addendum to these guidelines in the virtual world. So our objectives were to synthesize the evidence on the impact of COVID-19, which I'm not going to talk a lot about today as there's limited time, but we also wanted to look at evidence on virtual treatments and other online supports and technology for this population, and I am going to focus on that today. So when we met as a group in May, as a panel, we developed and honed in on these 8 research questions. So again, looking at the impact of COVID-19 on this population, as well as the treatments that can be delivered virtually, as well as self-help and other e-technology, including text messaging, smartphone apps. And then we wanted to look at more intensive services like day hospital, virtual group therapy, and meal support. We were also interested in a group on the question of when should individuals with eating disorders be seen in person, because not all treatment can be delivered virtually. So when do you decide you need that individual to come in for assessment of vital signs or their weight? And if they can't come in, how can we monitor them medically at home? We also wanted to look at the impact of sex and gender, and then what were the gaps in the research evidence? So our questions lended themselves well to scoping review methodology because we wanted to look at gaps as well. We had our library scientist, Neera, perform a search strategy, and we looked at all of the literature on the impact of COVID in these age groups. So our initial guidelines focused on children and adolescents. However, our panel anticipated there would be limited evidence, so we wanted to expand it to include emerging adults of age 18 to 25. And also looking at the impact or any supports for their caregivers as well. So Neera used the following databases that are listed on your screen. And we also looked at gray literature, so conference proceedings, abstracts, other databases of ongoing research. We had 2 screeners involved in first screening abstracts and then screening the full text articles, and we did have a third to resolve conflicts if needed. We ended up screening 1,300 articles in the COVID and impact section, when ended up including 15. And in virtual care and eating disorders, 6,500 abstracts, ending up with 69 included. In terms of our frameworks that we used, we also used GRADE to synthesize and classify the quality of the evidence. So putting similar studies together and then grading, are they an RCT or an open study or a case report, and grading it based on that methodology. However, we also wanted to incorporate elements from the AGREE framework developed by Melissa Browers, who was a member of our team. So these frameworks involve the consideration of preferences of panel members, as well as implementability factors. So let's say a treatment has all kinds of evidence to support it, but it's really not a treatment that clinicians or those with lived experience approve of or buy into, then we have to consider those factors when we make a recommendation. And this is sometimes hard for researchers to accept, that maybe our recommendation might be given a stronger or weaker level of recommendation based on opinion, which I will go into a little bit more later. So we pulled together our guideline team from our previous work, which included the core research team who assembled the evidence profiles. And we met with the guideline development panel twice, first at the beginning of the study in May to refine the research questions, and then in September when we reviewed all the evidence and produced our recommendations. The panel discussed and later voted anonymously on the recommendations. And if 70% of the panel agreed on the recommendation, it was approved. So these were our set of recommendations. I'm going to go through them quickly. So we first focused on telehealth using synchronous methods. So this is in real time, where a patient and therapist will be meeting online by video conference or teleconference at the same time. So CBT, or cognitive behavioral therapy, in a group format, achieved a strong recommendation for emerging adults. So there were a couple of studies indicating that this was very positive in terms of outcomes for body image distress. And the panel also agreed that based on previous evidence of CBT for bulimia, that this should be given a strong recommendation. We also had a couple of weak recommendations here in terms of family-based treatment, which is a treatment where parents are placed in charge of interrupting eating disorder behaviors. It's a manualized treatment that has a lot of evidence for it in real life, so not in the virtual world, but we extrapolated those findings from the real world. And there were also a couple of studies looking at virtual FBT that we thought we could propose a weak recommendation here for children and adolescents. We also gave a weak recommendation to the Maudsley model of anorexia nervosa treatment for adults. The acronym is MANTRA. This treatment focuses on many different perpetuating factors, such as it could be cognitions, it could be interpersonal stressors, it could be biological factors, and addresses those perpetuating factors so that the individual can focus on them and get well. So this treatment is mainly for emerging adults, and this was a relapse prevention method. So these adults had just left intensive services. In terms of self-help and guided self-help, here CBT also emerges as a treatment with a strong recommendation for many different types of eating disorders for emerging adults. The mantra shows up again here in a self-help type of format for emerging adults with anorexia nervosa. In terms of e-technology as an adjunctive intervention, the panel had a lot of discussion about this one. There is a very well-known app called Recovery Record, and this is based in CBT principles. This app has been shown to be helpful as an adjunct, and the panel felt it was important to emphasize that this is not standalone treatment for anorexia nervosa, and that people need to have standard meetings with a therapist, perhaps virtually in this world, but that this app could be a really helpful adjunct. And this got a weak recommendation. We also looked at caregiver interventions that were focused on child outcomes. So there is a recent study on guided parental self-help, an open trial, family-based treatment again. So the principles of empowering parents to interrupt eating disorder behaviors. However, this is a self-help version. So parents get a series of videos. They meet with a therapist coach for half an hour every week, rather than an hour full family-based session. And the child never meets the therapist in this guided self-help version. So this treatment has shown to have efficacy. There's another trial underway right now that is an RCT comparing guided parental self-help to regular family-based treatment in a virtual format. So that will be even more interesting when that result comes out. But this achieved a weak recommendation from our panel just due to the lack of very strong evidence at this point in time, but there is some evidence. Then we also looked at caregiver interventions focused on caregiver outcomes. So here we're not looking at whether the child or adolescent benefited, but did the caregiver benefit? And there was a strong recommendation here for cognitive behavioral therapy strategies, as well as a workbook and online modules recommended for caregivers of emerging adults and caregivers of children and adolescents with various eating disorders. And this would help in terms of parental understanding of their child's illness, or parental burden and parental self-efficacy. Those type of measures were used. We also had some weak recommendations where caregiver outcomes were concerned. So there was a study looking at parental meal support training, so a series of videos for caregivers of children and adolescents with various eating disorders. There was, again, these are looking at caregiver outcomes and not child outcomes. There was also a weak recommendation for moderated online caregiver forums and support groups for children and adolescents. Again, the literature was not resounding in this area. There weren't RCTs, but the evidence that was there was compelling. And so were the voices of the people with lived experience on the panel, that perhaps these treatments, or not really treatments, but supports, have not been fully studied, and they need to be. And the voices were strong that this should be given a weak recommendation. These forums and support groups are necessary for caregivers. There was also a weak recommendation for unguided caregiver self-help using psychoeducation videos, also focused on communication skills for parents of emerging adults with various eating disorders. Then we also had a couple of general practice recommendations. So The panel felt strongly and unanimously that individuals with eating disorders need to be seen in person at times for medical evaluation. Again, as I alluded to earlier, due to the medical component of this illness and the high risk associated with medical complications, these individuals need a check-in at times for their vital signs or their weight. And this should be accommodated even in spite of the pandemic. So guidelines should be followed, especially around admission. We should not be changing the bar for admission or the threshold. Given we're in a pandemic, that shouldn't really matter. We need to still treat these patients and admit them when clinically necessary. There was also very limited evidence that could be found on the impact of sex and gender. However, the panel again felt strongly and unanimously that marginalized youth and all equity-seeking groups should be provided equal access to treatment. And we go on to say in our guidelines that boys and transgendered youth often are not recognized for having an eating disorder when they really should be. The clinical vigilance around those groups needs to be higher so that they are recognized early, and similarly to girls when they present with eating disorder symptoms. So just moving quickly into limitations, there were a few citations we just could not locate no matter how hard we tried. We also had limited evidence on any sex differences, so we couldn't draw conclusions there. And we were unable to find any literature on virtual day hospital and virtual meal support. Hopefully, papers will be coming out shortly on these interventions, but at the time of this writing, we could not find any. Also noted is that some older studies used other diagnostic categories like eating disorder not otherwise specified. We would call that now other specified feeding and eating disorder based on the DSM-5. Also online, there can be diagnostic challenges. So scales are used that are not based on a threshold diagnosis, but does the patient have symptoms? Does the individual have symptoms that would make them eligible for the virtual treatment? Not necessarily a clinician has diagnosed them yes or no as having bulimia or another diagnosis. And again, I would say a challenge for us has been in our recent wish to publish our guidelines that a couple of the reviewers have mentioned the evidence versus the idea of preference, and taking into account the preferences of the panel, I would say are critical when you develop practice guidelines. So we're just in the midst of revising and getting back to our panel members about what reviewers have said, and then we'll proceed from there. So future directions, we need to look at the impact of sex, gender, and other considerations in virtual care, especially access for people who don't have internet. This is a huge issue. We need to look at efficacy of more intensive treatments and treatments that may be less intensive as well, like email, text messaging. And what do we do for those on a waiting list? Our waiting list has grown to 18 months over the last year, when typically it's 9 months, so it's really doubled. What can we do for those people? We also need to look at intervention for other diagnoses like avoidant restrictive food intake disorder and other specified feeding and eating disorders. So thank you very much for your attention today. And please, I would welcome any questions. And here's my contact information.
Thank you, Jennifer. We've got a couple of questions here that I'll just go ahead and pose. And this is just a wee reminder. You can type your questions in anytime and we'll take them in turn. So Nicholas has asked, can you speak to what virtual family-based treatment for anorexia for children and adolescents would look like concretely, like how it's actually done?
So virtual family-based treatment would be very similar to in-person family-based treatment. You'd just be meeting on a screen with the family at home. However, there are some challenges with it. In our second session of family-based treatment, there is a family meal where the therapist observes the family eating. And that's a little bit challenging on a screen. It's so much easier in person where you can see everyone clearly and you feel like you have more control over the situation when you're in person. But generally, the structure of family-based treatment proceeds as it does in the manual. It's just delivered online. So you're just following the same procedure. It's just a little more challenging with the meal and with weighing the patient at home, because a weight also is critical at every session of the therapy. And that means parents need to weigh their child at home when we used to do that in the clinic. So again, some additional challenges there that we're working through.
Thank you. Cynthia has asked, what would be an example of internet-based CBT-based self-help?
Well, if it's with so it could be a series of online videos where the young person or the caregiver access it through a platform or is given the series of videos. So it's self-help does not involve a therapist, but involves access to resources like video or reading material. That really is the context of self-help CBT. It involves the same principles of CBT, that you're trying to shift cognitions, but it's more self-directed, like the person has to do the homework all on their own without a therapeutic coach.
Thank you. Kylie has asked, what do you believe are some of the biggest reasons for the significant threefold increase in referrals for this population?
Thank you for asking that question. We have been trying to figure it out as well. And what we're thinking is that with a huge amount of unstructured time, like when kids, adolescents were free of any school structure, they were at home, and a lot of them report this actually, that they felt it was a great time to focus on their health, get healthier, exercise, and eat healthily. So a lot of them restricted their diet or changed it to be healthy, which to us as eating disorder providers was too restrictive. And they were exercising many hours a day. And so a trigger was perhaps this myth that they were getting healthier, but they actually ended up losing significant amounts of weight. And many of the patients we've seen, even medically unstable with very low heart rates requiring admission. So it's thought that unstructured time was a key factor. There's also lots of messages in the media about how everybody's gaining weight during the pandemic because we're all at home sitting around doing nothing, like myths like that. So that also contributes to young people worrying and thinking, I don't want to be that person that's gaining weight, so I'm going to exercise, but it becomes extreme. So this is why we think it's happening, but there could be other factors that we're not aware of.
Thank you. Sam asks, and this could be for Dr. Lee as well as you, Dr. Couturier, did the research that you reviewed, or to what extent did the research you reviewed collect real data and by that I mean race, ethnicity, and language preferences? And if not, what's our next steps in sort of generating some of that data as it relates to your populations?
Do you want to go first, Vivian?
Yeah, sure. So in our report, we actually stated that in reviewing the literature, both gray literature as well as evidence-based literature, there were no considerations for marginalized communities or racialized caregivers of autistic children and youth. And we raised the issue of we must be considerate of these populations as well and their needs, especially since I think in your presentation as well, there are questions about access to virtual or remote-based services now, which is where a lot of services have adapted their how they're accessing their families. And the question is, are these families able to access that care through virtual platforms? And if not, how do we work with them still during the pandemic?
Exactly. I would echo Vivian's comments. Same thing. We didn't find any commentary about these issues.
Thank you. And that ends our questions from the audience. If you want to type a question in last minute, now's your chance. And seeing none pop up, there's a lot of thank yous. One comment from Melissa, outstanding work. They thank you very much for sharing this information. So that is fabulous. Another says it was amazing. So yay. And I think that is the end of our time together today. So thank you, Vivian and Jennifer, for sharing your time and your expertise and research with us. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. Join us next week on January 26th and 27th when Children's Healthcare Canada is pleased to host the first Canadian Transitions pop-up event. Please visit childrenshealthcarecanada.ca for more information or to register. And our winter webinars resume on February 3rd at 11 a.m. Eastern when we bring you the Unclosable Hospital, telerounding, and its implications for children's healthcare. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thanks to Vivian and Jennifer for this presentation, and to CIHR for supporting our webinar program. Hopefully, we'll see many of you back here next week. Bye, everyone.